couple of things. We want to wish Paul Spencer a speedy recovery and to get over that winter crud that he has. Hope you're feeling better, my friend. And congratulations to Christine Hall, uh, who is a new grandma today. I think for what, the second time or
Yeah, third
Third,
time.
I think.
third time? Third, as they say, third time's a charm. All right, so I am joined by at least three of my good friends: Stephanie Allard, Scott Kraft, and last but not least, Terry Fletcher. Good morning. How are you guys?
Good morning.
Good. Good morning.
Good, good.
All right. Well, let's jump right into it because we have several great topics for discussion today. We want to keep one of them really short because I think there's not a whole heck of a lot to talk about. And that is the fact that the federal government, Congress, has extended the telehealth uh, uh, relaxed guidelines, if you will, that carry over from the public health emergency until at
5
least,
years ago.
yeah, 5 years ago.
That's all I'm
Uh,
saying.
they will carry forward until at least the end of September. So by October 1st, hopefully the federal government will figure things out. But I want to let Terry and Stephanie kind of take this for a few minutes because they've really been the ones, along with Christine Hall, that have really played a significant role in the education and information that comes out from our podcast regarding telehealth services.
So it was part of the CR, so the continuing resolution to keep the government open, the Congressional House Bill 1968. So you can all look it up or Google it, and basically, it just what it did is it where it said March 31st, 2025 expiration, and they just supplanted 9/30/2025. So not a lot has changed. A couple things, didn't make it in there, but again, we have some webinars. I know I do this week and next week, tomorrow with the NSCHBC, and then on Monday with McVeigh Seminars. So, check those out if you want to get all the details on that. But just know that how you're doing telehealth the first quarter, that's been extended through the end of the third quarter. So just keep that in mind. That's just an alert that was passed on March 15th, signed, but just also be aware, and then I'm just going to give Stephanie a quick shot of this because again, we don't want to belabor the point. Beware that there are limitations on audio only. There's certain things that have to be in effect, and people are like, "Oh no, we can just bill, audio only with 93 modifier." Not true. So there has to be some limitation. There are some limitations as far as you have to prove it, and Stephanie, I'll let you take it from this point because I'm seeing people going, "Oh, sweet, now that we can, do that," and I'm just like, I'm banging my head against the wall, trying to explain to them that it's only if. Go ahead, Steph.
Yeah, so I agree with that. And, one of the things that I'm still seeing up until an audit I was working on this past Friday is that there's still no statements in there. So when you're saying that, Terry, that really points to all of that because we still don't have practitioners even telling us if it's audio only. So, like Terry said, definitely do your research, look into the webinars, different things like that are out there. Um, it's one of those things where if you are currently doing what you did during the PHE, you're not going to be doing it accurately just from, the codes we had deleted, for example, at the end of last year. So you've got to research it, do a reset on all of it, and check out the different resources out there.
Yeah, and there's no shortage of resources. I mean, what these ladies have put out for the last several years is mind-boggling, uh, and I know it's been a tremendous amount of work on everybody's part, and I think everybody is grateful for you all being such a significant part of helping to make sense out of the insane. So, with that said, let's move on from telehealth and hopefully things will stabilize and we don't have to talk about it again until they figure out what they're going to do. Uh, Probably September 30th. the day
Yeah.
before.
Yeah.
All right. So, Scott, I know you have an interesting topic that you want to jump into, and I think this is really important because um, we don't often get the opportunity to speak to behavioral health and behavioral health, psychotherapy, medical records, things of that nature. So, let's jump in quickly and let's talk about what's going on in this area.
Yeah, I'd like to go grab my soapbox for a second on this one. So there's, as I think a lot of people know, behavioral health services have been a pretty heavy duty audit target, really again since the public health emergency 5 years ago. There's been a pretty significant uptick in the utilization of these services, and I'm seeing a couple of things as a reviewer that are concerning to me. The first, just to give a sort of top down review of psychotherapy documentation. We always want to understand what the goals of treatment are. I sometimes say there's not a big difference between psychotherapy and physical therapy in terms of the modalities are very different, but like the goals are somewhat similar, right? Like there should be goals of treatment. The patient should be making progress toward those goals. And the patient's progress may not be the way we would anticipated, so we might revise it or tweak it, but we should see that. And as the patient goes from session to session, there might be things that the patient's working on. We're going to circle back and see how the patient did with those things, see what's going on with the patient's life. So, the paradox of psychotherapy is that the documentation rules are not overly specific, but they are important. And so I'm seeing two things in psychotherapy documentation that are giving me a lot of pause. One is notes that are generated virtually entirely by smart phrases, smart lists, things that say, this is the modality of psychotherapy. It'll just be this very broad based kind of discussed therapy techniques with the patient, and the patient will try those. And I'm sitting there and I'm saying, boy, it would be nice to know what the techniques are. Because then I come back in the next visit and it's like, discuss techniques with the patient, patient will practice techniques. So these therapy notes should really be customized to the patient in terms of, if I'm the patient, we should have a clear handle on how I specifically am doing, what my specific goals are, and how I'm doing against those goals. And I should be able to discern that as being a distinctly different therapy note from, Terry or Stephanie or Sean. But increasingly I'll see these audits where I could take all 20 of the charts, redact all the names, put them in a pile and shuffle them, and I have no idea who's who. Like they're all the same. The second thing I want to mention is I want to be cognizant of psychiatrists who are doing sick visits. We'll say sick visits, management of chronic conditions, refill of medications, and their performance of psychotherapy services on a very intermittent, the patient happens to be here, I'm going to refill the medications, and I'm going to do like 16 minutes of psychotherapy. The rules are no different, right? So if you're the psychiatrist stepping in to do psychotherapy in those cases, that overarching plan of care should still exist. All of the personalization should exist. And I get concerned when I see patients who are seeing a psychiatrist, they're having their medications refilled, and then I'm seeing a psychotherapist documentation, like I did this 16 minutes of psychotherapy. Then I see in the documentation that the patient has a separate psychotherapist that they're already seeing once a week or once every 2 weeks. And I'm asking myself, like, what is the utility of this visit? Like, it has a sort of, I hate to say this and it's going to come out worse than I mean it, but it's almost like a drive by psychotherapy. Like, the patient's here, I'm doing the refills, let's just take 20 minutes and do psychotherapy. And I would just remind everybody, it's not that you can't do that, but one, all of the rules still apply. You should still have that plan of care. That plan of care should still be being revised. It should be medically necessary, and it should be purposeful and specific to that patient. And that's become a sort of increasing concern. It always has been to some degree, but the number of times I see psychotherapy notes where I'm just like, I have no idea what's happening here. Like the wording is very vague and it's really done for purposes of expediency. And so when you're saying things like, I discuss tactics or techniques with the patient, we should know what those are. If a patient came in for an injection, like an intra-articular injection, you wouldn't say like injected medicine into the body, right? And it has that same sort of vagueness to it, that I don't think is going to do very well in a third-party audit.
You know, we also see, Scott, and I know Stephanie could speak to this, is the same thing you just mentioned. And then all of a sudden we also see an annual well visit where we see
Yeah,
that's also listing medications and saying you're taking them and, adheredly. So I got several different providers saying the exact same thing on the same day in a separate note. And we're just like, okay, but who's the one actually today managing and dealing with that? And rarely do I also see the time met separately
right.
from the E&M. So
Yeah, and one thing that I noticed talking with various practitioners is that couple of things. I think there's a really big disconnect in this particular specialty between their clinical training and the fact that there's little and most likely none from the billing and coding side of things. Because a lot of times I'll get feedback that, for example, in clinical training, they're told to keep the information to a minimum. I even had one practitioner who had a set of notes they refused to show anybody, and then they would, scribble on another paper, psychotherapy 30 minutes, and they didn't show anything. So that's one thing that I find is really difficult in this space because it's a matter of getting the information out there, and more so in the behavioral health space if that's the only specialty they're in. Now, one of the things that I see often, especially like you were saying, Scott, if it's integrated into other practices, is that a lot of the times the macro statements say the same thing. And, I had a situation last week. I was auditing psychotherapy for patients who are in nursing facilities. One of them was stated to have mild dementia, but that's an area where we have to make sure that the note is showing that they can benefit from that they can interact. The words were the same, and then they were receiving therapy on a weekly basis. In every single note, there was no goals, no treatment plan. There was just the same paragraph every single week that said, generally what was done with that particular patient. So that's a huge part of it. Now, the last area that I find is really problematic is the fact that when we have practitioners who are doing the medication management, they don't always fully understand, again, probably because of this disconnect clinically and compliance billing side. They don't always understand that their education, for example, or any counseling that's related to the conditions and the management of those conditions with medication is inherently a part of the E&M service. So I have a lot of people who are wanting to do, psychotherapy. They put in their macro statement, education related to medication. And it's like, no, that immediately disallows it from a review standpoint. So there's definitely a lot of things that play into it that create the issues that you're talking about, Scott.
I'm also seeing now that it seems like I'm getting incidental diagnoses so people can add that 93 modifier. So somebody will say, um, instead of, the reality of what the encounter was, they'll say the patient had a little bit of an anxiety last week because of something. And, she was worried about if she was going to get a job. That is not mental health. And you just see this, and then they're like, well, we put anxiety in there so that we can, because we only were able to do an audio only. I'm just like, oh my gosh. So it's really it's really unfortunate that that's happening, but I do see people trying to get around the system, and it drives me crazy. But I have a question to Scott and Stephanie, because again, behavioral health is maybe 5-10% of what I do. um, and I know you guys are in it. Do you have issues with privacy? I'm not seeing the HIPAA security that we used to have, with like AIDS and HIV and psychiatry notes, psychology notes that we used to have. I'm just seeing them in the, kind of in the general population of EMRs. Scott, I'll start with you. Isn't that supposed to be kind of in a separate area and not as easily accessible?
It is, and I will tell you, client by client, it's been different for me. So I have clients where I might do behavioral health as a component of a larger multi-specialty audit. And a lot of times we all just forget there's a separate permission structure for that. So I start doing the audit and I'm like, okay, how come I'm not finding any of these notes? And then it kind of hits me, okay. And I have some clients who will print them for purposes of redaction. and scan them. So they print, they react everything, you know, A1, A2, whatever that might be. And then, yeah, to your point, there are some where it is really not as closely monitored as it should be. And there's multiple different ways to do that, right? You can have break the glass, you can have different ways to quarantine these notes or kind of put them to the side. But really, all of those things are supposed to address what Stephanie had mentioned earlier, which I've also seen where some therapists will just hide, I'll say hide for lack of a better word. They have a separate note that nobody really knows exists, while there's this very vanilla sort of front facing note. And for better or worse, we can't, I can't take your word for it. That's not how auditing works, right? And so, we have these protections in place so that when these notes need to be seen for purposes of, payment validation or compliance or whatever it might be, that we are able to view them. But you're right, they should be managed separately. There should be a separate access path. And I think that's critical when we think about, people who work within practices. I mean, I can't tell you how many times we've been involved with different clients where there are clearly under the surface like HIPAA issues, patients looking at, or excuse me, employees looking at coworkers' charts, all manner of things, right? And so I'm glad you brought that up, Terry, because I think it's very important to sort of navigate what you're saying and what like Stephanie and I have seen. Like these protections are in place because at some point these notes are part of the medical record and they do need to have some visibility in certain circumstances, but that's what that added layer of protection's for. And the paradox with what both Stephanie and I have seen, so the one client I saw that did it, they just kept them in a separate drawer in a filing cabinet, and the drawer had a lock on it, but this wasn't like Fort Knox level, I'm going to need, a soldering iron and the goggles or anything, right? If I put my foot on it and pull, I'm probably going to be in there. So, that's a last part of that. You may be trying to do something that you think is more secure and is in point of fact less secure.
Well, in the Cures Act, doesn't the Cures Act, and then Sean, I want you to speak to that too, is, when that came out where the patients are entitled to their medical records on a very wide scale, one of the things in the Cures Act, CURES, for anyone who's looking it up, was that the doctor can write a statement if they feel that the medical record that they want access to will hurt them in any way. They can deny giving them that, but they have to have a reason for it and make sure the patient has it in writing. And one of them was if it had anything to do with criminal activity, which I'm like, okay. And the other one was, psychotherapy notes. And so in saying that, a lot of patients now are getting more and more, I don't want to call it savvy, but more and more awake to the fact that they can request their notes. And again, just to me, not just the, like you were saying that, Sean and I were talking about clinical documentation recently, integrity, but just the access seems to be a little too much right now. Sean?
Well, yeah, I love this conversation, and it's been hard for me to sit here and keep my mouth closed because I struggle with that, but I didn't want to take away from the great things that you guys were talking about. So here's a few things to keep in mind, right? So under the Health Insurance Portability and Accountability Act, psychotherapy notes are held to a very strict standard of confidentiality, which require patient authorization in order for those medical records to be released, with the exception of a limited number of circumstances. Now, one of the things that you were talking about, Terry, is how is it that patients are gaining more almost unfettered access to their medical record? My chart is one of the things, depending on, if you're part of, if you're going to a health system that uses the Epic system, you have My Chart, right? And it notifies you when there's a new test result, when there's a new document from your provider or whatever it is. So patients are, if they sign up for these portals, they're given all kinds of access to it. Now, when we start talking about issues where there are potential administrative, civil, or criminal proceedings, there are very strict standards that have to be followed on behavioral health medical records, substance abuse records, rape victims, child abuse, things of that nature. Um, Oftentimes, attorneys will make a motion that's referred to as an in-camera inspection, which means that prior to these medical records being released for the general consumption of legal counsel on one side or the other, that they first have to go to the judge who reviews them in private chambers. That's what in camera means. It's a private review in chambers by a judge to review the aspects of the medical record that the motion being made by one side or the other is saying it could be detrimental to either the patient or another person if this information were to be released. Stephanie and I have a very large behavioral health client where I am constantly having to deal with the Commonwealth of Massachusetts, and now with their expansion into Rhode Island and New Jersey and New York and some of these other states. Because you will find in some states, the laws are a little more progressive, a little more liberal than what you find in other states where they're much more conservative. But what I would tell people is, and obviously this program doesn't provide legal advice or legal guidance. Make sure you reach out to your general counsel, your contracted legal counsel, if you're looking for specific legal guidance on a situation. But these records, to Scott's point, not having a locked file cabinet that is really impenetrable is a bad idea to be storing medical records of those individuals with behavioral health issues. Those need to be held to the highest standards, to the strictest standards possible.
Sean?
Yeah, please.
One thing I noticed that not everybody has checked is people who work remotely. They haven't checked their firewalls. They haven't checked where they're keeping records. I mean, the PHE was like, everyone go home. And so then a lot of people stayed home, but nobody checked to see. I had one really bad case where there was oh my gosh, the provider was freaking out. And I didn't mean to interrupt you, but this was really a big deal. Is that, like Scott was saying, they decided they wanted to redact some of the records. And so they sent a paper file of, I think it was 100 charts to this person who worked from home, but they didn't do a great job redacting. If you held it up to the light, I don't know if you've ever seen the movie Hidden Figures, which is awesome. You just hold it up to the light and you can see what's going on. But her daughter, who was in middle school, she needed some paper for homework. So she grabbed some off the table because she worked at her kitchen table. She didn't have a separate office, didn't have a private space to work. Nobody checks. And I still have seen offices like, well, we don't really monitor that. And I'm just like, oh my gosh. So she used the back of some of these, these copied notes, took them to school, turned them in for her homework. Turns out the teacher knew someone who that was their patient, and shared that information with somebody else. And I mean, the domino effect took place, and it was a nightmare for that practice of what happened. And so I think people forget that, it's kind of like staff going out to lunch at a local restaurant next to their practice, talking about patients and their information, not realizing a patient's waiting to have an MRI and decide to go to lunch at the same place and heard it. And they're like, oh my gosh, so I don't know if anybody on the panel can speak to that, but I think, because 99% of my business is now remote, and we have firewalls and certain things. I know Stephanie and I both have, cybersecurity, all that kind of stuff, but I don't see that a lot of practices remembered to do that.
Well, you got to do security risk assessments, right? It's one of the things that is, required under the Health Insurance Portability and Accountability Act. So pinging, your employees' systems, making certain that you're challenging the integrity of their, their use of a VPN to be able to get in through the back door so that it's secure. Making sure that your folks aren't, when they're at an airport using the public Wi-Fi, or when you're on Delta using the Delta Wi-Fi. I mean, those things are not secure. That is open to the public and
Starbucks.
Starbucks. So be very careful about that. you've got to pay attention to this stuff because, one violation could cost you hundreds of thousands, if not into the millions of dollars. And I've seen, I had one client who their initial demand from OCR was $16.2 million. Now, it got negotiated down, but at the end of the day, it was still a significant amount of work that had to be done. Scott and I have a very interesting client that we share together, doing the compliance work. And, we are constantly battling the issue of healthcare individuals, nurses, techs, administrative people going into other employees' medical records, and I'm not making this stuff up, and out of spite pulling information, or it could be harmless, where somebody says, "Hey, Scott is my cousin. I know he works at this health system. Could you do me a favor? Could you go in and pull me my last lab results for my lipid panel?" And Scott's like, "Yeah, sure. It's only a lipid panel. What's the harm in that?" Um, but that's a violation of the organization, or at least should be the organization's policy on who has access to the medical records. There is something in the guidelines that is referred to as the minimum necessary standard, which means based on an individual's job, it should dictate what access they have to the various aspects of the medical record, because not everybody who works in a medical practice should have access to all parts of the medical record. Scott also, and this is the last thing I'll say, and then I'll let Scott kind of jump in and take over. Scott brought up a very good point just a few minutes ago, and I'm not sure if anybody caught it. There's a program called Break the Glass, and it is a security protocol, and I'll let Scott kind of define it more. But what it basically does is it locks down a medical record. And unless there are certain permissions that are granted to certain individuals, nobody can access. It is like the Fort Knox of a protection that they place onto a medical record. And I will tell you, there are people that want their stuff locked down. I know this sounds crazy, but I am one of those people that wants my stuff locked down because of my continuous engagement in federal, civil, and criminal trials, and people being malicious to try to find health information or any information that they can use against an individual. So my stuff is locked down. I promise you. But you have a lot of celebrities out there that people are like, "Oh, holy cow, Ursher showed up to the emergency room." If anybody remembers who Ursher is, I think he used to go by Usher. Um, Shows my age.
Like, who's Ursher?
Ursher. He used to be Usher. Come on, man, get with it.
I know Usher. Right?
So, anyways, I'm just making something up. But this guy shows up to an emergency room, and all of a sudden, everybody's like, "Oh my God, I'm going to sell this to TMZ, and I'm going to make $1 million." So that's sort of what we're talking about. But Scott, go ahead and jump in and talk more about it, because this is such a critical thing, and I hope people are paying very close attention, because HIPAA is not something to put on the back burner. This is something that needs to be front and center in your organization, as much as auditing your actual clinical documentation.
Yeah, and so break the glass is definitely how Epic describes it, and other EMRs have similar phrasing. But break the glass adds a layer of restriction to a patient's chart, and that layer requires me as an external reviewer, for example, when it comes up, I have to state from a pre-selected list of reasons that are more broad-based why I want to look at this chart. And then I may have to go in and clarify further what my purpose is. And that is then going to give me access to the chart, but it's also a flag that's put in place deliberately for various reasons. I tell the story sometimes. I don't know if I've ever told it on this podcast, but I think it speaks to what Sean's saying. Like, when I was 16, I worked at a Costco style like membership club that doesn't exist anymore. We'll say it that way. And at one point, we were all just bored, kind of sitting at the membership desk, and we started like looking up famous people, and we're like, "Oh, I wonder if this person has a membership here," And it was like this was like literally the late 80s, right? So whoever was famous like 30 plus years ago, and you would find people, right? And you'd find somebody, and like their address would be in there. And we're really just looking up, like, does this person shop at this? It was called Pace, by the way, this membership warehouse. And to
I
think that
remember
people,
Pace. Oh my god, because I was sitting here jogging my memory. I'm like, okay, it's not BJ's because they're still around. It's not Costco. It's not Sam's. I
yeah, it was
remember
Pace, and
Pace.
Pace got
Yeah,
sold to Sam's, right?
Sam's.
So, and to think that people wouldn't do that in medical practices is crazy, right? Whether it's, like you people are going to be sitting in practices and they're saying, well, who's the person who's on the 6 o'clock news in my town, right? I wonder if they've ever been in here, right? Who's somebody might be in the news because they're suspected of some kind of crime or something. Someone might gain notoriety for like a minute for something that they did, and so all of these protections and setting that culture are important. And the thing, what I would say, like when you think about doing a security risk assessment in your practice, think about clear security risk assessments that have been done in other settings, right? Like if you go and you check into a hotel, they don't hold up the thing and say like, "Hey, you're in room 204." They kind of write it down and they slide it over to you. And so when someone's at your front desk checking in, think about it the same way, right? Like you wouldn't announce why they're there. And you want to think about all of those controls like all the way through, right? And that includes how people access your systems, how you cordon off behavioral health records, how you cordon off anything that's sensitive, and that includes, I mean, we worked with a client, or we have a client where there was a fairly significant crime in the area where the client operates, right? And so they had a protocol in place to lock the records down. And it's just somebody has a responsibility, right? Like anytime somebody's name comes up prominently, lock the record down, especially if it involves a situation where they're probably brought into the facility. And those are things that we should all be cognizant of. And just to put a bow on this, related to what Sean said earlier, your policies in terms of internal discipline and review should be very well known and very consistently enforced for these violations, because the risk to you is not worth it, right? And so you should not have a cavalier attitude towards, well, this person looked up somebody's record they weren't supposed to look at, but I'm sure they won't do it again, or it doesn't really matter, right? I think these are all important things to be mindful of.
Yeah, and I just want to add lastly here, when it comes to psychiatric, behavioral health, all of these different records, we also have to keep in mind the patient population. And, I want to be sensitive in the way that I say this because obviously there's a lot of different diagnoses that exist there. But with the client Sean was referring to, we have a lot of situations where the patients are, upset for whatever reason. So then at that point, okay, they're like, we have a right to our information. And one of the things that I've noticed helping this particular group work through access, patient access, is the fact that they also are going to need training or think through the workflow as to who's going to be communicating this with the patient. Because there are a lot of times that the patients are going to react with a lot of anger, even with the detail of the note, right? When we think about, okay, what's the level of information that's going to be in there? Some of them don't like that they have a particular diagnosis, or maybe the details that are documented, they don't want them there. So, it's one of those things where the whole practice needs to be looked at. And, from my viewpoint, when we were helping work through the workflow part of it, I didn't really think that it would be appropriate to just have, somebody on the billing team, for example, reach out to the patient to give this information. Even when the practitioner has the right to not provide the full document, they have to summarize that. And sometimes that's going to aggravate the patient because they're not receiving the full document. So just think through all of that. And, we also want to think about provider protection as well. There's been times where this was years ago, Sean. I don't know if you remember this, but there was a situation where we had, I believe it was a therapist, and there was a local crime that had happened, and there was a patient seen running through the streets, like acting very psychotic.
Yeah.
And they were picked up by police and they were claiming to be this therapist, and that it just happened close to their home.
Yeah.
So it ended up not being related, but just think about the provider's exposure as well, and what that can do to their mindset, their safety,
Yeah.
obviously patient safety as well. But
I do remember that. That was in the Commonwealth of Massachusetts.
yeah,
That was that was a scary situation where
yeah,
you had a mentally um um,
unstable at the time.
unstable individual. Yeah, thank you. You had a mentally unstable individual posing as a therapist, and yeah, that's a frightening thing. Um, it's funny because Terry wanted me to remind folks as well that this even happens in our federal government, and this has led to, and I believe they were looking at criminal prosecution of these individuals when our vice president JD Vance, his medical records were accessed from his military days at the Veterans Administration by individuals. You know, folks, listen, please, you know, claiming stupidity in trying to prevent yourself from being criminally charged is not an acceptable defense. Being stupid is not a crime. It's just unfortunate that you're stupid. So understand what the rules are, understand what the laws are. Um,
Sean,
is
you know how sometimes you say you probably said it wrong?
That's gonna be a clip.
That's good. I think you're making yourself a meme.
sorry.
I
I
think
know,
we need a bumper sticker that says, what does it say? Don't be stupid, or you can't claim what did you say? It was funny. I'm
well,
sorry.
stupidity is not a justifiable
It's not a
defense. Being
yeah.
stupid is just unfortunate.
T-shirts.
Um,
It
is
is
that one of those
unfortunate.
where you guys have to reel me in?
A little bit, because
Okay,
people are gonna be
well,
like, "What did he just say?" And
I
I
but
want to replay it.
I, I know, but and listen to anybody who I don't ever mean to offend anybody. I mean, I'm just a very plain spoken individual, and sometimes things just come out. My wife calls it verbal vomit. But anyhow, um, be cognizant of this. Don't go in and say, "Well, I didn't know I couldn't." Use common sense. Really, HIPAA and this is actually how the Health Insurance Portability and Accountability Act was presented. It is a common sense act. These are common sense laws. If I don't know Dwayne Johnson, The Rock, but I work in a hospital in Honolulu and I know that The Rock was there, should I access The Rock's medical record? The answer is no. How do I know it's the answer is no? Because common sense tells me I shouldn't be accessing The Rock's medical records because I don't think The Rock would be very happy if we were accessing his stuff. Okay, let me pause there before I say something else and get myself in more trouble. So, Scott, go ahead and jump in, please.
My last point on this, because I know we talked about as a component of this, the patients having access to their own medical records with higher frequency. I just wanted to add that in addition to privacy, that's a nice reminder to make sure that the things in the medical record are accurate, and make sure that when a patient looks at something, they're not going to say, well, that didn't happen. And we'll talk about that in the context of other topics today, but we recently had periodically through Doctors Management and NAMUS, like patients find us and patients will say, well, you guys seem like you may know the answer to this. And a patient reached out and basically said, well, I'm having a problem with my medical note because I recently did a 7-minute phone call with the provider relative to like COVID and treatment. And the patient had a lot of other issues with this thing. But the patient was like, well, I looked at the note and the doctor said he spent 20 minutes. And I know it wasn't 20 minutes, it was 7. And, that's a small example of as these notes become more prevalent in terms of patient access. And I'm going to talk about it a little bit more in context of one of our other topics, but I did want to make that point.
Which is
All
a
right.
good way
The
to.
No,
patient interviews too. Don't
Yeah,
forget, if there's
They do.
concerns, they will go out and interview the patients.
absolutely. So, all right,
It's a good with
let's
leadway into the split shared visit.
I'm actually reading some of the comments because we're on so many different platforms, and I'm reading some of the comments that are coming in. People are actually phonetically putting out Ursher
I know.
and talking about the need for T-shirts for some of my isms. Okay, listen, if I can afford to do T-shirts, I'd do them. Maybe I'll pre-sell them. I don't know. I'll come up with some good ones. All right, so let's jump into our last one because I think this is a great topic. This has to do with split shared services. Okay, so folks, we are not going down the path of incident two. This has nothing to do with in-office ancillary services that are being performed. This has nothing to do with direct supervision, anything that translates into incident to billing. This is split shared services. These are very different guidelines, different sets of requirements. These are for the inpatient hospital setting or skilled nursing facilities. It has to be an inpatient facility in order for split shared services to uh, apply. So, Terry, why don't you lead us down the road, get us started? And I know Scott and Stephanie, you guys have worked with me extensively on split shared services, giving presentations at annual conferences and writing reports and things like that. So I'm going to let you guys handle this one. Go ahead,
So I'm
Terry.
just
Thanks.
gonna kick it off and then send it out to the panel. One of the things that I think we see sometimes is people slipping back into the old E&M guidelines. And I know Scott and Stephanie both see that. We see it because the EMRs haven't been updated for, the 2021 and then into the 2023 update. And I think also the habits of the old guidelines seem to slip in as well. And one of the things that from the previous guidelines, when it came to a hospital encounter, where both the physician and the QHP, qualified healthcare provider, which remember that practitioner has to be a PA, nurse practitioner, clinical nurse specialist, somebody who can independently bill for their services to the payer. It's not an RN, it's not a clinical staff by definition. And so one of the things that it used to say was that the doctor had to sign off and do something other than sign off. It was really gray area. Well, that's not the case anymore. As of 2023, AMA updated, CPT updated that information, and Medicare agrees. And I'm just quoting right out of page 5 of 2025. It says, if the physician or other QHP performs the substantive portion of the encounter, the physician or other QHP may report the service. If the code selection is based on time on the date of the encounter, the service is reported by the professional who spent the majority of the face-to-face or non-face-to-face time performing the service. So here's where we run into some trouble right now, is that everyone wants the 100% of allowable that the physicians get versus what the QHPs get. Well, a sign-off alone, it does not tell us substantive portion. No time in there about and split time, who did what, during that time, and the list of activities doesn't give us who did most the majority of the time. And so even though sometimes I get frustrated with AMA because it gets very, I don't want to say gray, but it leaves a lot to be desired as far as specific mandate of what you need. And then you have to fall a little bit to best practice. This is what their intent was, which sucks because I'm sorry, but that's sometimes I know practices don't like that. But we're getting still a lot of, these split shared visits. First of all, I'm not getting the FS modifier, which is wrong. You have to put it on there. Somebody said, well, I only put it on there if the nurse practitioner PA is filling it out. No, you got to put it on there no matter who's providing it to identify that was a split shared visit. But you also have to meet the guidelines. And I'm just not seeing it. I'm seeing sign off. And so when that happens, from an auditing perspective, I will adjust it and say this should have been billed out under the lower valued service. You can't have it as a provider higher valued service if you can't reflect who did what. So Scott, I'm going to send it to you then, Steph.
Do we have like 2 more hours today?
I know, right? Oh my gosh.
Well, don't forget, we also have one more topic that we have to get to, which is the contract issue with UHC.
So I'll be
Go ahead.
brief, but I'm going to
No,
start by
go ahead.
I'm going to blame CMS for their wishy-washiness on this topic for the last like 5 years. right? They tried to change this to be whoever billed the most time and then this substantive piece. And what I hate the most, and Terry, you may have, I don't have my book in front of me, but you may see this. There's a section of the way the AMA describes the split shared visits that says something to the effect of, the physician may document that they have reviewed the documentation and taken responsibility for the treatment plan as documented by the nurse practitioner or the mid-level provider. And this has led to this expansive amount of nonsense where, to me, like, I try to keep my life simple, right? And everything should make sense. And when I say everything should make sense, what that means is if the MD says they spent 20 minutes and the nurse practitioner spent 15 minutes, the nurse practitioner should not have documented the entire note, done all of the medical decision making, and then I'm left to wonder like what exactly the physician did. And I have these instances where I'll see these statements that from the physician that say like, I did all this. Like they don't say the nurse practitioner is a scribe, but they say, I'm responsible for all of the medical decision making in this note. Like I created it all. I'm the one who did it. And there are these statements strain the credibility of the underlying documentation as it appears. And so like my guidance on this is just stop screwing around with this stuff. Stop trying to fly as close to the sun as you can without hitting it. If the physician's going to take part substantively in the service, have the physician go in there and document medical decision making that's reflective of the work that they're doing. If they're spending more time, I should feel that when I read the note. I shouldn't see a note entirely created by the nurse practitioner and then the physician is saying, well, somehow I spent 25 minutes, but I just looked at the labs and read the note, right? Like you should be thinking internally about policies and procedures that make sense because I don't care for that CPT book language at all. But I've seen that come up time and time again as the path that, physicians are trying to take in their documentation to say, well, this says I can sort of claim all of this as my own. And I think it's risk for the physician because they may not be reading these notes closely. I don't think it reflects a substantive part of the service to just go in and smack these smart phrases in, often, by the way, 2 and 3 days after the visit. And I just feel like if you're going to do this, there ought to be a way that you can do it where you substantively document medical decision making, similar to what I said about psychotherapy, right? Make it real about this patient and take the 5 or 6 minutes or whatever it takes to document it. And that's where I'm going to bring back what I said before in closing, right? Make sure that things you're documenting in the note are things that actually happen. Because if you're documenting in the note that you saw the patient and this note gets under third party review and the plan goes to the patient and the plan says, according to this note, you saw Dr. Smith and, Jess, the nurse practitioner, and the patient says, well, I didn't see the doctor, that's problematic for you. Sorry, I'm
Well,
taking
and
my soapbox and putting it away.
one thing I always say, especially when I'm working with physicians, is that if it feels like they're attacking your workflow, it's because they are. And that's why I feel like we had these different things that CMS was trying in the past that they got pushback on. But, there's so many times that I meet, especially with nurse practitioners, and they're frustrated because they are the ones who are doing the bulk of the work. The physician wants to come in, say hi, walk out, and then bill for the service. So, it's just one of those things. I won't go much further than that, but it's a workflow issue, which is why it bleeds over into compliance for quality issues there.
All right. Nothing else that I could add. I think you guys hit it out of the park with this this discussion on split shared services. And to Pam's point, I wish we could just do away with split shared services. I wish we could just do away with incident two. In all sincerity, I think it would cut down on an extreme amount of confusion, and it would eliminate some of the indictments that we see that include violation of the incident two billing provisions. Okay, last topic, and this was a great one because this actually this discussion started, Terry, for you and I within a society that we are currently members of, and it's the NSC-HBC. And it was brought up that United Healthcare was putting terms and conditions into their contract requiring 24/7, 365 unfettered access to the electronic medical records or electronic health records of all beneficiaries within, um, you know, within a practice. And the problem is you can't segregate access for somebody only to get into UHC records. But UHC kept pushing back and saying, well, it's not a HIPAA violation because we are a covered entity. We have BAAs, we have, this, that, and the other. So there was a big discussion that came up, right, Terry? Listen, one thing everybody knows, if I say something out of context, Terry will call me out for it. So I mind my P's and Q's. So there were a lot of responses about this is a HIPAA violation. And while I agree that there was potentially an argument to be made about HIPAA, I think the argument regarding the lack of need of consent by UHC was going to be the point that they were sticking to. But
Well, the one thing, Sean,
ahead,
one thing
please.
I was actually trying to figure out, I don't know if the word's collusion, but the one thing I didn't like that UHC did, and, I audit for them, I educate, that company. So, I'm not talking out of turn. They know my position on this, is that what I didn't like is that it seemed like some of the new contracts to be able to get signed, you have to agree to give them unfettered access to your EMR, not just for labs or for things specific to them. They just
Right.
want to be able to look anything up and get into your system, which no. So I said it to Sean going, is this legal?
Yeah.
And so this is, weird because, and especially because you don't know where this information's going. Consent is a big issue, like Sean said. Is every single patient in your population now going to give consent for a company that they are not a part of to have access potentially to their system? But also now with AI pulling and extrapolating information, that brings up a whole other issue of privacy issues and, again, consent. What are you, getting into? But I mean, and then I get into the fact that what if there's, and this is probably a stretch, but there's a certain company out there that, you spit in the envelope and you basically find out what your DNA is from. Well, that company is filing bankruptcy.
Yeah,
And that's going to be
23andMe.
Yeah, well, I wasn't going to say it out loud,
Oh.
but okay.
Oops.
but I was trying to keep it, neutral. But that they're saying it's going to go to the highest bidder in bankruptcy court. So all these millions of people's DNA is going out there, and I'm thinking,
Start deleting.
and it just started getting my wheels spinning with this UHC thing,
Yeah.
going, anyone who has unfettered access, and doesn't it go back, and I'll throw it again to, Scott and Stephanie, doesn't it go back to what we were talking about as far as protections for the, psychotherapy records and just for sensitive information?
Yeah.
There seems to be so many breaches in HIPAA.
Well,
I
agree
I'm
with
at a
you.
loss.
Yeah, I agree with you. And I think we could have the discussion about, minimum necessary standards and access and what should they. So the argument that I put forward, if you remember, Terry, on the message board was, to me, I think this was a most favored nations clause violation. And if you're not familiar with what a most favored nations clause is, and the reason why I put this forward was because I started thinking about the fact that it could raise antitrust concerns, right? Because it could be used to restrict competition or maintain, higher prices, right? Because these insurance companies, if they get in, and this wasn't just to the patient medical records, this was access to the entire system, which included the PMS. So they could look at your contracts and they could understand what you were getting paid by other insurance companies. So there was collusion, there was antitrust issues. But so my argument was, look, we are not allowing any other insurance company to have access to our medical records, and we're not granting access to UHC. And I think if you want to go down this road, you're getting into uncharted territory. Well, I got to actually work on this case with my good friend Jackie. Is it Colt? Is that how you say her last name? Jackie Colt. And Jackie took the argument and they presented it back to UHC. UHC actually changed the contract and said, since the practice does not offer access to any other insurance company at this time, UHC will not require access to the EHR system. However, and this is where it became a most favored nations clause argument. However, if in the future that should change, by which the practice now allows access to the EHR, you must notify UHC and grant us the same access. That is a most favored nations clause, because if you think about it, an MFN clause in a contract ensures that one party receives at least as favorable terms as any other party, guaranteeing they won't be treated less advantageously.
But John,
That
I'm
is it.
getting now
Yeah.
that the loophole, because that was just for her client. It's not a
Yep.
blanket thing that USC changed. Or, yeah,
No,
I don't
but
know if
that's
they
what I've
changed.
been using for my other clients to push back.
Right. Well, I've had a couple that saying, well, you give pharmacists access to that for prescribing, and they have, you know, payer access, or you give this access for people that, you know, things are sent over. And I'm like, that's not the same as
No, it's not the
unfettered
same.
access to get a medical record.
No.
So but it's you know, again, I'm not an attorney, you know, so
No, but I
the
believe
legal
these insurance
challenges.
companies are going to use it for nefarious
I
purposes.
do.
I do.
I do too.
I
Well,
absolutely do.
remember
That's just the nature
too,
of the business. Go ahead, Steph.
prior to the breach last year, they started an investigation into UHC and the fact that they own a piece of every part of our industry, which is incredibly frustrating.
100%.
And not only that, but if you remember, there was some kind of, and I don't remember all of the, you know, details, but something had happened where there was some voice recordings available where they were being pushed from a risk adjustment side to do things to make the patients look worse.
Yep.
So that would be my question too. You know, we have issues with them sending people out to patients' homes to try and fill out forms to get risk adjustment. They're doing things like, you know, going into problem list. So if you have unfettered access into a system, are they just going to sit there all day long as well and go in and try to pull out all of that information? It
Yeah.
just doesn't make sense.
And if I'm not mistaken, I think that was the settlement agreement for like $330 million. UHC had to, and if I'm wrong, somebody please let me know, but I believe that was what they had to issue the settlement for, was escalating the HCCs to make patients look more sick than what they actually were. So, you know, I think at some point the federal government, as much as I don't like overreach of our federal government, I like a smaller government. I think this is one of these where we need to see some, we need to see the House Appropriations Committee, or we need to see the Senate Finance Committee get involved, investigate this, because I do think that with UHC having their hands into every single aspect of this industry, it potentially creates a very difficult situation for those of us as healthcare professionals trying to navigate how do we work within the parameters that are being established by an organization that has unilateral rights on just about everything, because they control everything from the PBMs to the distribution to the adjudication and processing of claims to the auditing and recoupment to how the appeals process works. So I think at some point someone is going to take a much closer look into these insurance
Well,
companies. Scott, go
HHS
ahead.
secretary
Yeah.
is, you know, Kennedy.
Well, and
Oh yeah, I think that's going to happen. But Scott, go ahead. Let me give you the last word.
You know, and if they're in your practice management system, who's to say they can't assess your collections acumen or timing?
Absolutely.
You know, if I have United Healthcare right now, and in 2026 I change to Aetna, like, what does that mean? Does that mean they have unfettered access to all of my stuff? Does it just back through 2025? I mean, this is a Pandora's box of like second guessing. And, you know, look, the one thing that's unique in our industry to some extent, and I think will protect us from AI for maybe an extra 6 months, is that the practice of medicine is a very non-standardized thing. Like if I audit two orthopedic surgeons within the same entity, their practice styles and what they may choose to document may be very different. What we choose to count for code assignment is more standardized, but when you're trying to look at that at 30,000 feet without that approach, it's just a lot of second guessing, right? Well, why did you treat this and not this? Why didn't you document this HCC with a plan? And it's just somebody on your shoulder telling you what to do all day. I don't know very many people who like that.
All right. Well, that's going to bring us to the very end of this episode. I want to thank Stephanie, Scott, and Terry. Paul, continue to feel better, my friend. And Christine, congratulations on that third time becoming a grandmother. That's a wonderful thing. All right. To each and every single one of you, thank you so much for tuning in, logging on, and hanging out with us each and every single episode that we are able to come live to you on the Monday Auditing, Coding, and Compliance Roundtable. Terry and I are going to be back tomorrow. I can't wait to hear what she hits me with as a topic of discussion tomorrow. As always, I'm sure it's going to be fantastic. We will be back in 2 weeks with a brand new roundtable discussion. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care. See you soon.